last topic, that's lumbar canal stenosis, minimally invasive technique by Dr. Rana Patri. Go ahead, Dr. Rana.
Greetings to everybody. While treating patients of lumbar canal stenosis, my personal preference is to treat almost everybody with minimal invasive surgical techniques. A variety of minimal invasive techniques exist while treating lumbar canal stenosis. The most commonly performed, and the one I perform personally, is using a transportal microsurgical unilateral laminotomy and bilateral decompression. This also can be done endoscopically, and similarly we have other procedures like bilateral fenestrations, minimal invasive TLIF. These are procedures I also do microsurgically, but these can be done endoscopically, either by a uniportal technique or a biportal technique. In this day, there is very little controversy regarding the benefits of minimal invasive surgery while performing a decompression in a lumbar canal stenosis. Here is a study which is a systemic review and meta-analysis which gives level 1 evidence that unilateral laminotomy and bilateral decompression is associated with a higher satisfaction rate, less back pain, less blood loss, shorter stay, and all these with similar complications as an open approach. There are additional benefits of minimal invasive surgery, which includes lower cost of hospital stay and lower infection rates. Surgery on the lumbar canal spine can make it weak structurally. Here is a patient with a normal lumbosacral spine in flexion and extension. We can see on the MRI that there is a canal stenosis at L3, 4, and 4, 5, which are both decompressed by the minimal invasive technique. And we have postoperatively listhesis at L4, 5, though the L3, 4 site is quite normal. The structural weakness caused by surgery is quite variable depending on the type of procedure. Quite clearly, the minimal invasive surgical techniques leads to a much more intact structural integrity as seen in porcine studies. Here we have 2 studies, and in one we see that the laminectomy group exhibited more instability, and in the other the postoperative stability was best with muscle preservating interlaminar decompression. There is an ongoing controversy regarding role of fusion versus no fusion in spondylolisthesis associated with lumbar canal stenosis. There is a trend in the US for fusion being performed in almost all patients having spondylolisthesis. While if you look at the other study, which is a study from Scandinavia, where there is a mixed bag of patients, some with spondylolisthesis and some without, who were treated with fusion or no fusion, and it was seen that there was little difference in the outcome. In fact, if you go into the reoperation rates, it was similar at 22% in the fusion group versus 21% in the decompression alone group. The truth of whether to fuse or not to fuse is probably somewhere in between, and each patient must be judged by their own particular clinical profile. It is worth going into the natural history of spondylolisthesis to understand this. A long-term study by Matsunaga, where they followed up patients with spondylolisthesis to see what were the factors which caused slippage. They saw that the potential contributors of progression was a lower intercostal line, trophism and sagittal orientation of the facet joint, increased pelvic incidence, increased mechanical loading across the disc space, and general joint laxity. While the predictors of no slip progression were essentially those which showed signs of restabilization, such as greater than 80% loss of original disc height, spur formation, subcartilaginous sclerosis, ossification of ligaments. In patients who also have scoliosis, it was seen that reoperation was significantly greater in patients who have a scoliotic disc wedging with a Cobb's angle of greater than 3 in L4-5, along with a lateral listhesis. In a systematic review of 24 studies involving almost 2,500 patients, which investigated the role of laminectomy causing iatrogenic spondylolisthesis in lumbar canal stenosis patients, it was concluded that instability was a common problem with patients with established spondylolisthesis. However, instability may occur less commonly when using minimal invasive techniques. Some of the salient points in the surgical technique. The first step is to dock the port correctly. This is done by having the orientation perfectly perpendicular to the floor and directed to the inferior edge of the superior lamina, which is also oriented to the superior end plate of the inferior body. Here's a depiction of what we can actually see through a tube. We see the interlaminar space. This is an important anatomy to identify right at the onset, to orient yourself to the anatomy, as well as define the inferior limit of the surgical exposure. Subsequently, the ligamental flavum is defined along its entire extent, right from the inferior edge to the superior edge, and also going across the midline by undercutting the spine and defining the apex of the ligament and flavum. These two pictures depicts the anatomy as seen through a port when we're trying to look across the midline to the opposite interlaminar space. The first picture shows the port, which is directed slightly superiorly, the inferior edge of the superior lamina. And the second shows the pedicle, the pars on the opposite side. And also you can see that the inferior edge of the lower spinous process hides the anatomy behind it, and that anatomy is important to find. So we have to burr off this area to expose the anatomy behind that. Subsequently, once this is defined, we use a cutting cautery to cut along the apex of the ligamental flavum over here, and this helps us in removing the soft tissue intervening to expose the opposite interlaminar space. Once this is done, we complete the sublaminar bony decompression, and in the end we then remove the entire ligamental flavum and complete the operation by with chisels and kerrissons, removing the opposite medial facet joint. In conclusion, there is class 1 evidence that decompression helps in lumbar canal stenosis. A minimal invasive approach is better than a laminectomy. There's also class 1 evidence in this. Select group of patients may benefit from fusion. I've listed what are the criteria which can be used to help us in making that decision. As a routine, doing fusion in all patients of lumbar canal stenosis and of even of spondylolisthesis is questionable. Thank you very much.
Thank you.